So I'm glad that we have quite a few people joining us in person. We have and we're having people join us via Zoom. So welcome to those of you coming in remotely. We are in for a big treat today. So I'm going to get started here so we can use our time wisely. So without further delay, I'm going to introduce our Dean, Javier Nieto, who's going to introduce our speaker. Thank you, Javier.
Thank you, Marie, and thanks everybody for your patience. We are still in the process of solving some technical difficulties. I think we are getting there. But so just a couple, this is a hybrid session, so we have some people here in the room, some people in Zoom. For those of you who are in Zoom, is in a webinar format, so please, if you have questions, use the Q&A feature in the Zoom webinar window to put your questions, and at the end of the talk, I'm going to be moderating, reading your questions and passing it on to the speaker. So it's my great pleasure to introduce to you Dr. Alfredo Moravia, our speaker today. Alfredo trained as a physician at the University of Geneva in Switzerland, and then did a residence in internal medicine and in occupational medicine. Then he went to Johns Hopkins, where he did an MPH and Master's in Science in Biostatistics, and a PhD in Epidemiology, and I had the pleasure at the time to work with him. We shared advisor. We were teaching assistants together in an EP2 class. He's currently professor of epidemiology at Columbia University School of Public Health in New York, and also in the Queens College in City University of New York. Before that, he served as director of clinical epidemiology in the University Hospital in Geneva, Switzerland, and also served in Mount Sinai School of Medicine and Penn State College of Medicine as faculty before going to New York. Alfredo is currently editor-in-chief of the American Journal of Public Health. He's been editor-in-chief since 2015, but he's also in the editorial board of Preventive Medicine, International Journal of Epi, American Journal of Epi, European Journal of Epidemiology, et cetera, et cetera. So he has extensive experience in this field of editorial work and publications. He has done some work in recent years on the cohort study looking at cardiovascular health of first responders in the World Trade Center after September 11th. He's author of more than 400 publications, including editorials, peer-reviewed articles, and author of 8 books and multiple book chapters. His leading area of scholarship is history of epidemiology and public health. He has these 8 books, as I said. I have 2 of them. One of them is signed by him. I hope he signs the other one. Anyway, so without further ado, thank you, Alfredo, for joining me, giving me a warm welcome to all of you.
Thank you very much, Javier. I mean, I've known Javier for 40 years. And I can remember the day I first saw him because we were in those classes. We did our PhD together. We had the same advisor. And we were in this class of biostatistics. And there was this Spanish guy who was asking all those smart questions. You know, I said, where is this guy coming from? And I've learned to know Javier so well. He's very hard worker, extremely smart person that I've been always very impressed by. So I'm very happy to be here, and I was glad that he invited me. You are living in a paradise. I mean, who would have known? I mean, OSU is hidden somewhere in Oregon, that you get here and you find an incredible environment and beautiful school, etc., and great faculty. So I'm really extremely happy to be here. And I would like, to speak this time more with my hat of historian than of editor. So even though there will be some of the journals there, I've been an historian of epidemiology since historian for a long time, but specifically of EpiMethod since the 1990s, and that's where we published this first book. And I still am very interested, but when I became editor 6 years ago, I just had to stop because, to be a historian, you need a lot of space time. You need to be able to immerse yourself in the time and live in the century and all this thing. And when you're an editor, you just can't, like when you're a dean, you just can't be a historian. So this is work that I've done last year, actually, because Bernin has gone.
He said to remind you to hit the unmute button.
Yeah, but we only have part of the screen. That's normal? Okay. So don't worry. I mean, if you see it. The first thing I'd like to tell you is about the center where I am at City University of New York, Queens College. It's the Barry Commoner Center. So anyone know who Barry Commoner was? No one. No one knows Barry Commoner. So that's why I need this short introduction, because this is Barry Commoner. He was in the New York Times cover, the ecologist of the year. He's he's one of the first ecologists of American ecologists. He's been very, very productive. He's got terrific books. Maybe you've heard about that, Closing Circle. I read it not so long ago when I got to the center, and I used to have lunch to prepare my lunch along his. I was doing my salad, and he had every day his salmon or trout fished, which he put on bread and a huge piece of onion on top of it. And so that was his daily meal. And I was preparing my salad on my side, and we talked. And so I really recommend this book. I mean, about the fact that everything is connecting in nature and why you cannot change something without affecting something else. It's so wonderful. But Barry is also a candidate for the presidential election of 1982, and he ran against Ronald Reagan. And he, of course, didn't win, but he did a beautiful campaign, and that was his vice president, interestingly, an Oklahoma Comanche, whose name was Harris. Isn't this okay? And so there was different aspect, and Barry there. So that's a center that CUNY has dedicated to Barry Commoner. It's a very small center with 3 faculty and maybe 50 people work there. But I thought, I like to remind who he was, because he's been a very influential and important person. If anybody has heard of the teeth study that was done in the end of the 50s, where they got teeth from babies and measured the radioactivity in the teeth and used that to show that there was radioactivity from the atomic bomb experiment in New Mexico that affected babies throughout the US. He saw Lyndon Johnson, he showed him the data, and immediately Johnson stopped the experiment. That was also Barry. Anyway, so what I'd like to discuss with you today is how pandemics affect methods in epidemiology. And last year, the Journal of Clinical Epidemiology invited me to write this, and I've been, of course, I had not thought about that before, but I thought that maybe there was a connection, because there have been always important changes after each major epidemics, of the size of what we are going through now in epidemiology. And in some ways, it's expected, because it's a science that is in close contact with reality and with society. But I mean, I could talk about the plague, cholera, flu, etc. But I would just want to compare two epidemics, because they had important consequences on the method. HIV/AIDS, which really transformed epidemiology very profoundly, and COVID-19. I want to show you how it showed the limitation and in the current methods, and where we should be working in the years to come. So this was the cover of the July issue of the journal, about the 40 years of. Do you see well in the back? It's clear, or we should dim the lights, or? Okay. So in June 1981, it was 40 years after the description of the first cases of disease that would become associated with HIV. And so this is the comparison of those two epidemics in terms of number. HIV/AIDS evolved over 40 years, 33 million deaths worldwide, 76 million infected. And you see, more or less, half of the people infected, a little bit less, die from the disease. On the other hand, you have SARS-CoV-2 that have 5 million deaths by now worldwide, but 250 million infected, and a case fatality that is much lower. So SARS is going to infect many more people, but probably kill less people. So there are two very, very different pandemic. So, oops, no. Because I need to have this for later. I'm going to be playing with, like a DJ. I'm going to be on my computer. So this is the evolution of AIDS death in the US between 1981 and 2000. And you see, the story really starts in 1981 here. And then we'll come back to this graph. And now you see that the mortality is going down, but you had a peak around at the beginning of the year 2000. It's still extremely high. So how did it start? In 1981, the CDC journal reported that there were 5 cases of young men dying from a disease, pneumocystis carinii, which was a disease that people usually see in people that were highly immunodepressed, and so it was hard people didn't know what it was related to, and they noticed that all 5 were infected with the cytomegalovirus, and there were an hypothesis that maybe CMW would depress their immunity and would explain the disease. So this was 1981, and rapidly, and I insist this because then you'll see the contrast with COVID-19. Rapidly, as soon as 1982, and I'm going to show you that part of the report. As soon, a year later, we knew which were the population affected by this. And so they were mostly homosexual, bisexual men. Then they were IV drug users, people from Haiti, and without a history of homosexuality or IV drug use. Then there were people with hemophilia, and etc. And a few persons from other groups. So we knew the distribution in the population of the first cases rapidly. We'll see with COVID that it took us a very long time to really know what was going in the population and where. On the other hand, the epidemiology, epidemiology really thrives when the lab doesn't work or is not yet ready. When we cannot get the direct microorganism or direct cause, the toxin, or epidemiology gets associations between some exposure and the outcome, and we have this ability of finding association before we can explain fully them fully. And so we had a window of opportunity which was totally missed. I mean, for the epidemiology, totally missed the opportunity to say that HIV/AIDS was an infectious disease. It totally missed it, and this is probably the most, in some way, infamous report from epidemiologists about the causes, but it identified one specific, whereas all the other reports in epidemiology were saying, it's maybe a drug, it's maybe a type of sexual relationship, it may be, they had CMW, they had lots of hypotheses, but not a specific one. This study was done in New York, and it was a case control study of homosexual men, and they compared 20 homosexual men with another of these diseases that was new for them, Kaposi Sarcoma. Again, a cancer that was known, but very rare out of Africa, and usually that was much less invasive than those cases. This was a very invasive form of Kaposi Sarcoma in young men, and so they took 20 homosexual men from the same clinic and 40 control. They compare the habits, and what they found is that there was a risk ratio of 12. Okay, 12, and it was actually an odds ratio because it was a case control study, but that's how they call it. It was in Lancet for people who used very frequently a recreation drug called poppers or amyl nitrate. And so that was really the major factor that came out with, of course, a very strong confidence limits that were very far away from one. And they had a second risk factor, which was sexual activity, but we had only a risk ratio of 2, but was also statistically significant. And it was a very difficult situation. I mean, we have to, the fact that they conducted the study and rapidly is really, very remarkable. And the context was difficult because there was a tendency for the government then, and it was, the Reagan administration, etc., to associate the disease with homosexuals. And if you were saying, it's some sexual, some drugs taken for sexual activity by some subgroup, you were actually going to support this idea that the administration was promoting, that it was a disease of the homosexual and not of the rest of the population. So, I mean, if you were focusing on sexual activity, sorry. So they focused on amyl nitrite and they say maybe the drug is depressing the immune system and explains why some men have that use them very, very abundantly have actually a Kaposi sarcoma. And so that was, of course, wrong. And it took another year, and the solution was given by the virologist who found that it was a virus that was causing Kaposi sarcoma and depressing the immune system of people and favoring the appearance of diseases like pneumocystis carinii, Kaposi sarcoma, etc. So EPI missed it. And why is it that epidemiologists failed to see that it was an infectious disease etiology? Because EPI was totally focused on chronic diseases. And it was the epidemiology of tobacco and lung cancer, of all those dietary factors causing cardiovascular diseases. That was the main ground of epidemiology. All the methods of epidemiology had been developed around situation in which you had an exposure at one point in time, and then you waited the risk time period, and then you had an outcome. And that was very clear-cut, no time dependent. So the new epidemiology that was called modern epidemiology was actually summarized and presented in its most elaborate way by its thinker, Olli Miettinen, in a 1976 article of the American Journal of Epidemiology. Just the title give you an idea, of what was in this article: estimability and estimation in case reference studies. So, I mean, you can start to think a little bit about what this means, but it was very difficult. I can tell you we struggled enormously to understand these articles, but it ended up that Olli Miettinen had a new approach to epidemiology, which was much more quantitative. Before that, epidemiologists were essentially thinking about what was going on in population, having hypotheses about association, and then doing some case control, cohort study, etc. What Miettinen brought was a mathematical, explanation to what epidemiology, to the foundation of epidemiology. And this graph summarized all of epidemiology. All of a sudden, we had a graph that explained that the underlying population was a dynamic population in steady state, as he called it, that people were moving into the non-exposed into the exposed, the non-exposed without the disease into the non-exposed with disease, exposed without disease into exposed with disease. And this was the risk period, the exposure was taking place here. And then the cases were accumulating over time. And if you're comparing those cumulative outcomes, then you had a risk ratio. And if you were looking at the time, for the incidence, the occurrence of a case for each unit of time, then you had a rate and rate ratios. And all of epidemiology could, and you could derive, what was a case control study, what is a cohort study from this graph. And all the graph had two variables. It was person and time. And so what does it make you think? Person and time was the equivalent of space and time, right? And that was the physical, theory. And we had a theory for epidemiology that was, comparable in the sense of its simplicity and its scope. So that was the graph that underlined all of the modern epidemiologic activity, and there was no time varying factor. It was a very clear-cut relationship between exposure and outcome. So now I would like to make you listen to Miettinen explaining his graph. And let me see if this will work, because you won't see the face of Miettinen. That's Mietinen.
Very nice that you had a figure about this thing. But depicted there is a stationary dynamic population in motion all the time. So the population has its particular segments according to the exposure history, exposed, exposed, or non-exposed, and when the entire candidate pool might have those events occurring. And so the idea is to get people to understand that it is not that every study or causality is a matter of following a cohort. An etiology study is typically, by far, a matter of following a dynamic population. And as I had told you, epidemiologists still don't understand that duality. A dynamic population is defined by a state of being, such as citizenship in a country or population membership in a city or whatever. And so it has turnover of membership because the state is a transient state. You are a member through the duration of that state. So the population is open for exit, dynamic population. And for alternative, it's a core, which again people don't understand. It is a population defined by final event occurring. And once the event occurs, you remain a member for the rest of time, meaning through death and eternity.
Okay, so I'm not asking you whether you understood everything that Mietinen said. I just want you to know, who Mietinen was, because that's very important. And what he just said was incredibly right when you think of what happened when infectious disease reappeared. He was really a genius in the sense of that he understood epidemiology in a very original way, but his communication ability were, a different story. And now I read his work, I understand it very well, but in the 80s, it was really hard, really extremely hard to understand. But this is the thing. We were in an era where epidemiology was following, these ideas of Mietinen. Morgenstern was a student of Mietinen. He published a book about Mietinen's ideas before Mietinen. So that was a source of conflict. And then there was this famous case control study by Schlesserman, who also integrated Mietinen's idea. And finally, in 1985, Mietinen published his own, he published his own book because it took him 7 years to find a publisher. And he published him in somewhere in Holland. I reread all this book. It's by far the best. By far is the only one that stood the time. All the other ones have things we recognize today, erroneous. This one is the only one that stood the time. But the thing is that it was very complicated. And finally, in 1986, you had Ken Rothman translation in some ways, adaptation of Mietinen's idea, which made them available to all of us. And when this book came out, that was modern epidemiology could really begin. I remember I was at Hopkins then, and one day one of our friends came with the book and he said, that's the book. Now we finally have it. And so that was the 80s. And that's when the HIV epidemics was growing very fast, and epidemiologists didn't have the right method to approach it. So that was the reason why this window of opportunity was missed. But a few years later, a drug for the treatment of AIDS was discovered, and the issue of testing it became an important matter. And running randomized trials was difficult because people wanted to have the drug and they would do anything to have it. So having a real randomized trial and making sure that the drug was not used also by the people who are not supposed to have it, or the placebo, was very, very difficult. And so the idea of using observational study to actually make sense of the data and try to answer the question about the efficacy of those treatments came out. And it happens that at that time, so, sorry, this was the type of problem that needed to be addressed, which was totally incompatible with the previous form of epidemiology. You had an exposure which was changing with time. And so if you have a treatment at time 0, your treatment at time 1 is going to be influenced by how your CD4 are. You know, if they are up, you may not have it. Down, you may have it, and then you will have the final, association between the treatment at time 1 and the outcome. But if you only use this as it would have been in the traditional, in modern epidemiology, you would miss all the people that were, that died because of the very low CD4, and you remain with the group that is actually which has actually a better prognosis and get the drug. And so if you do this, you have the impression at the end that the treatment is protective, because you miss the whole story. You need to have those treated here, their evolution here, and also what happened to their CD4 and other factor that may influence whether they get the treatment or not. You need to take into consideration all those time-dependent variables, which was absolutely not possible in the tobacco lung cancer type of association. And so there was a need for models that could take this into consideration, and this didn't exist in epidemiology. But in psychology, there was a new theory proposed by Donald Rubin, which did exactly that estimating causal effects of treatment in non-randomized studies. So how do you do to actually create a situation in a non-randomized study which has the same characteristic as a randomized study? So in the randomized study, the randomization creates groups that are very similar in average. In non-randomized study, you have two groups that are different, because those who get the treatment have some reason to get it, and those who don't get have also some reason not to get it. So this makes two groups that are so different that they are impossible to compare. And the idea of Rubin was to actually take the whole population of the study and consider it once the whole population is exposed and the whole population non-exposed. And this was what has been called later, causal model, because it was based on this principle. If, let's say, you have an individual that has a flu, and you give this individual an antibiotic, and the person gets better in the following week, okay? So how do you know the antibiotic had a good effect? You don't know, because it may have occurred like that by chance. And so the only way you would know is to go back in time, take that same person, but go back in time and don't give the antibiotic to that person and see whether that person would go better after a week or no, which is, of course, impossible. It's impossible at the individual level, but you can do it at the the population level by treating the whole cohort in your study, once as exposed, once as non-exposed. So that was the idea of Rubin, and they began to apply it in psychology, and it wasn't used in epidemiology until 1986, and James Robbins, who was an assistant professor then at Harvard in occupational epidemiology, understood that the ideas of Rubin would help him to solve a question in occupational epidemiology that had never been solved before, and it was called the healthy workers bias. And it was exactly the same idea then that I told you about with HIV and the treatment of HIV and the time dependence. So in this paper, which I haven't read, it's almost impossible to understand. It has 119 pages. And so he actually applied Rubin's idea to this problem of the worker effect, healthy worker effect. So maybe let me explain to you because reading it's a bit complicated. But let's say you want to study the effect of an occupational exposure on some cancer. Okay. And this occupational exposure can kill people, right? Or can disable them so much that they have to leave the job. So you would have people who were heavily exposed, were sick, left the job. And then you find yourself with the people who remain and are exposed, which were the healthiest of the exposed group. And then finally, you find an association in which being exposed is protective against the cancer you were studying, because you miss the fact that the most exposed and heavily affected workers had left the factory. So you are only left with the healthy workers, and that's the healthy workers survivor effect. And so you can show it with the same graph that I showed you before. You have a toxic exposure that have an impact on employment, and the people who are most affected would live, would not be here because they would not be employed anymore because they got the disease or died, etc. And then when you finally do the traditional analysis, you'll find healthy worker exposed compared to non-exposed and the protective effect of the exposure. So that was the bias. And Rubin understood that by using Rubin's approach, he could actually integrate those time dependence factor and integrate not only the latest situation, but all the history of the cohort that had been in the factory, and understand what was actually the real effect of the exposure. So that's the way that that these ideas are presented. You know, for those of you who used with decision analysis, there are kind of decision analysis tree, and you can go up each of the branch and recompose the probability of each of those branches, and then you wait for those probabilities and you get the final measure. I'm going to explain this to you a little bit more. I just wanted to show you that that was already in the original paper. So when the AZT treatment came, Rubin understood that he could actually apply this same method he had applied for the healthy worker effect to the evaluation of the effect of AZT. And that's what he did, and he reported it in a much more readable article that had only 45 pages, but it's approachable, And he explained how you could use non-randomized AIDS treatment data in order to evaluate the effect of AZT. And he did that. And that changed completely the role of epidemiology in this new phase, because finally we were able to actually contribute to knowledge in the treatment of AIDS, which was the last thing left to do since the etiology had been already solved. And so the method that were developed as a consequence of the HIV/AIDS epidemic, the way it transformed epidemiology was extremely profound. And now you know those models, they are taught, there is a textbook about it, etc. So this was the same trees applied to HIV/AIDS. And here I have, oh, this works. But we have no sound, but this works. Oh, this video works. So maybe I can put the sound here, and you'll have both the sound and the, so, and I really think it's important for you to listen to those two thinkers, you know, Jamie Robbins and Mietinen, because they've been, you know, besides Javier and Sklo, they really transformed epidemiology in okay, so.
So here's some causal inference, and scientific papers consisted mainly of epi and biostatistical analyses, so enrolled in some classes, and quickly learned biostatistics is the old days, foundational is a dirty word. So I got into it because two problems caught my attention. One was the bias that due to the healthy worker survival risk. In fact, I've had suspicion that the builder explained that article without a solution. And think of an occupational mortality study where you have common death from chronic obstructive pulmonary disease. And so individuals who read work receive no further exposure. That's what it means to report more exposure. But they're also at greater risk of death from COPD because some of the individuals leading work have unreported COPD. That's why they left. But we don't have data on deaths. So reading work is a confounder for the effect of subsequent exposure. So that's this classic situation. Okay, I'm going to stop it here. It's more for you to have an idea of the communication skills of these epidemiologists who have been so, you know, influential in the way they've transformed our approach of things, you know. And so often they need to be working with people that have more communication skill and can translate all this. And this is now a textbook, you know, Miguel Hernan and Jamie Robbins have their textbook, and it has become, you know, the normal approach to many problems. I mean, to all the problems in epidemiology, which require time-varying variables. And so I mean, this you can find in a paper by Hernan that explains to you that if you actually consider, you know, you have, let's say these are old people and young people, those are exposed, non-exposed, you have the outcome. You can analyze the whole cohort of old and young if they were all old or all young,
and then you combine all this, and when you introduce the weights, because it's just a standardization approach in its simpler form, then you see, and you, instead of having 5 and 3 people, you have 5.2 and 2.8 instead of having 12. So you can standardize the comparison in order to remove the effect of confounders, but in taking into consideration the time varying characteristics of those confounder. So it's of course impossible to explain in 2 minutes, but if you take the time, you'll see it's very understandable. So now let's look at COVID-19. I think COVID-19 was an extraordinary possibility for epidemiology to show its usefulness, and the success have been tremendous. This is an article from Nature, how epidemiology has shaped the COVID pandemic. And many people, don't realize that most of the knowledge that we've been having, at least already in the beginning of 2020, came from epidemiology. Very soon, this was an article of January 31, 2020 in Lancet. We knew the thing was coming, and there were some projection of how important the pandemic was going to be and how it was disseminated. Very fast, there were assessment of the possible impact of a reduction in transmissibility if it wasn't reduced, and there were no mobility reduction, and if there were 50% transmissibility reduction, no mobility, etc., and what would be the actual progression of the pandemic. This was in England, also estimation on the different scenario of closing school, personal protection, etc., with different R0, number of people infected for each case infected. All these things appeared very fast. We knew, for example, the days from infection to symptoms, we knew it was about 4 days, extremely soon. The days from illness to onset, there was another, about 10 days, and all those notions were available extremely quickly. The fact that people in the higher age group were at higher risk of dying from COVID. This was also early in 2020 available. I mean, the impact of mask usage, on the incidence of cases of COVID-19 was also available very fast. So all these were extremely successful aspects of epidemiologic intervention, the opposite of what was seen after the HIV/AIDS pandemic. I think in terms of modeling, R0, case fatality rate, incubation time, subgroup at risk, the impact of isolation, quarantine, the importance of contact tracing, the effect of personal protective equipment, the infectiousness of the different variants, the vaccine efficacy, and effectiveness, we had this very fast. They were absolutely impressive how well epidemiology has responded. The problem is that almost all the COVID-19 data we had until today have been of very poor quality. Actually, the best quality data now we have is vaccine. And this for the journal was a big problem because we knew the pandemic was not hitting all groups in the population the same way. There was huge inequities. They were clear. But should we publish data that are actually biased because they are based on convenient sample, no real denominator, things we would never have published before? So we said, no, we won't. We wrote clearly, we know we're not in this altogether, but we actually are not going to publish data that we need to a year from now to remove or withdraw, etc. And we invited 4 epidemiologists, very authoritative epidemiologists, to write a piece in the journal explaining what type of data we would publish and what we wouldn't. So the journal really focused on what will happen when for public health when the pandemic will be over. But I want to say that the lack of data has been a real disaster. And this was an article in Politico, Inside America's COVID Reporting Breakdown. And this is a quote from this article. Failure of effective tracking of the pandemic by nearly all, if not all states. Patchwork of underfunded, understaffed, poorly coordinated health departments, and decades out-of-date data system, none of which were equipped to handle the modern-day public health crisis. And the system of surveillance and survey in the United States is very complex. It has a lot of different system and institutions, and it's completely failed at the beginning. The good news is that the reaction of the people in those surveys and the administration was extremely fast, and they've improved the system tremendously. I know I'm a little bit short in time, and so I'm kind of going fast, but what was missing was really random sampling. We didn't have data, population data, that we could report to a clear denominator. And this was possible. There is a case in Spain where they had a national sample, and they took a random sample of the population. They got antibody test and seroprevalent serologies, and they were able to report last year the seroprevalence results, to give an idea of what was the proportion of the population was infected. It was very low, 4%, last summer. That was really, really low. And we would have needed that for all the other regions of the world. And hopefully we'll be able to emulate what the Spanish group of Dr. Poyan has done and have the same thing in the future. The optimistic note, and I'll finish with that, is that our December issue has reviewed the state of most of the survey and surveillance system in the country, and what they did was extremely important, and they are much better now. And they reacted very fast. We're going to have a national health and examination survey next year. I mean, all these are back up. So that's what I wanted to say. The HIV/AIDS epidemic, transformed epidemiology from modern epidemiology to the addition of those causal model. And hopefully COVID-19 will help us to improve our surveillance method, which have been really neglected for many, many years and are essential to respond to an epidemic. That's what I have to say. Thank you.
Questions from here, from the room? Barry?
Thanks. That was really a fascinating talk. It's interesting with, like you said, like epidemiology did a lot of things right in the COVID-19 pandemic. But it seems like we're getting a pretty bad rap as well. And so do you think that's just communication, like politics? Because I know like a group of economists came out and said like these epidemiologists don't have the tools to deal with this. We need to come in and help. And
yeah.
And so
I see exactly your point, and we're at the, having all this pressure on us at the journal. I look at what we've done, in 8 months, because I have the data for August, we've vaccinated 300 million people in this country. I mean, the large majority of the people get the vaccine, accept, the idea of wearing mask, of being prudent, etc. I mean, there's a minority of people. Of course, they're more prevalent in some states, etc., in some areas. But if you take most of the country and most of the cities and most of the population, we're together behind that. But there is this extremely vociferous minority of people that are able to bring this message that maybe epidemiology has failed. So I don't want to have this message coming out in the journal because it's incorrect. I think we should be conscious of the huge success that we're accomplished. I think the pandemic hasn't said its last word to the people that are non-vaccinated, and that at the end of the story, we may end up with a much more positive situation. So we have to be extremely prudent with not thinking that this minority of anti-vaccination people represent a lot of people. Now, yes, there is an issue of understanding what is public health and what is medicine, and public health needs to be enforced. This is a message that probably goes beyond the anti-vaxxer, and that's our goal today. Our challenge is to re-explain that public health is a way to respond to collective threats, and to respond to collective threats, we must enforce collective responses. And since they are collective, they are safe, because you cannot impose a collective response which is dangerous. You have a disaster, So that idea of public health needs to be refreshed, if not, developed in people's ideas. So be careful, in some ways, that do not let this minority of people contaminate too much the debate and discussion.
Yeah, thanks. Unfortunately, we're out of time, but
that's my fault. I took too long.
For the questions and for the attendance, and thanks.
Thank you.